into and then we even have some of the questions already, so we can kind of reuse those unless new questions comes up. So welcome everybody to this webinar that we are just going to do for the second time now, because we started at 4 and it should have been at 5. So yeah, I am in Germany today, visiting a doctor in Germany, and yeah, so I'm just going to show you the room and location. I'm in his IV room. He's getting patients tomorrow for his IV treatment, so I was given this room. So very kind of him. I just want to hope that you have all had a very lovely summer. And then I want you to know that we are continuing developing the VMS, and I'm hoping that next week we will be able to, or I will be able to send out the demonstration on how to make your own journal notes in Nordic VMS. So you can make your own template where you can add a picture of your logo, you can add your signature if you want to do that. The system can automatically add the patient name, date of the journal note, and also if you have the date of birth or like a personal security number, that can be added as well. But I will show that in the demonstration video so that you can do it yourself and cut in and so on. And you can make all the templates you want. You can make them in whatever languages you want them to. I have one for first consultation, and I have it both in Danish and English because I also see international patients. Then I have follow-up in both Danish and English, and then I have short follow-ups in both Danish and English. Then I have specific ones for children. So because then it's the parents are there and it's just doing it in different ways. So I'm looking forward to sharing that function with you. And then of course this recording will be shared. Now we can choose which one is the best one to share because we will have 2. And of course you are allowed to ask questions in the chat, and I will try and take a note of them so that we have Q&As at the end. I know Graeme will ask me some questions in between, and I'll try and answer the best I can. Graeme, you're the star of the show. Get going.
This is Groundhog Day. You did very well with your repeating of everything. I'm kind of now worried for my performance, but yeah, let's get started. I'll share the PowerPoint here. Hopefully let's okay. Can we see this? Is it good? At least that's better than the first start where we're missing off the bottom. So yeah, welcome everyone. And yeah, today we're going to talk about all things intestinal permeability. So the IPA test, intestinal permeability and absorption, and IgG testing. 2 much more simpler tests to discuss in general compared to Dutch or CSAP, much bigger reports. And yeah, both of these tests are very interesting tests. So we'll get through, of course, the standard questions like why is IPA and IgG testing helpful and under what circumstances. There's definitely some different opinions on both of these tests from all sides of medicine. We'll go through some basic result interpretation, treatment strategy options, and we're going to talk. I'm going to get Anne-Catherine to repeat some of her case study examples, and we're going to show just some results. So we'll hopefully then get to your questions as well. So when to consider an IPA test. So here is a kind of summary of some of the research data. We have on the left-hand side perhaps the most obvious column, because of course gastric ulcers, etc. in that first left-hand side, they're all based in the gastrointestinal system. So it's not a surprise to consider, well, if someone has, for example, IBS or IBD, you might consider an intestinal permeability and absorption test. Now, I think clinically, where I've been using this test, it's more in monitoring of situations. So not using it to just give a diagnosis of you have hyperpermeability, or of course what's been known as leaky gut. Our gut is supposed to be leaky, it's supposed to be permeable to, of course, absorb food and nutrients. But what we don't want is this hyperpermeable state where potentially, bacteria or endotoxins are making their way across, or across the mucosal lining, the epithelium. So here we have some very obvious cases. Left-hand side, we've then got things like allergies in the middle, chronic inflammation, NAFLD, NASH, and then on the right-hand side, even things like PCOS. Now with intestinal or hyperintestinal permeability, there are many associations, but we can't prove causality. So just something to be aware of, that you may have a patient with a whole number of different symptoms. You may run an IPA test and you may do your best to address that, but it might not resolve all the symptoms. So of course, we see a lot of patients that have hyperpermeability with a lot of other dysfunction as well. Interestingly, hyperglycemia is perhaps one of the worst things besides alcohol for hyperpermeability, and PCOS, of course, associated with insulin resistance. As with diabetes and obesity, they're definitely conditions which drive up permeability. And then we have things like traumatic brain injury. So we can, through, of course, damage to the blood-brain barrier, it also seems to cause damage to the intestinal barrier. So those two barriers very seemingly closely related. So generally, if we're losing one, the other is being affected. And then, of course, things like trauma as well. So surgery can affect the permeability of the GI tract. Now, our permeability analysis, what it's mainly looking at is small intestinal permeability and gastric permeability. To look at colonic permeability, you need a test that reviews for a much longer period of time. So you want to bear that in mind when you look at the results, that you're looking at the small intestine and the gastric mucosa. So if you've seen me lecture before, you might have seen this slide, because I think it's important to really say, from a research perspective, underlying causes are surprisingly rarely disease specific. So we, like I said before, we might see hyperpermeability with healthy patients. So there's no disease present or syndrome. Again, does it mean that there's something really bad is going to happen? Not necessarily, but we can also see with very diseased patients, hyperpermeability going on as well. But of course, my goal is still, regardless of the case, to try and improve that situation. But the reality is probably permeability is perhaps changing all the time based on what's going on in your life and environment. So if you do public speaking, then the permeability is probably increasing due to the stress of that event, for example, or the stress of doing something twice. So definitely more hyperpermeability for me at the moment. Now, if we get into the architecture of a healthy gut, so I think it's important just to cover that situation. Of course, we have the small and large intestine here. So we have different different types of, or different anatomy going on. So we have continuous epithelial barrier with tight junctions. We have the villi and the crypts in the small intestine. We also have crypts in the colon as well. In the small intestine, we have a single mucus layer. We have two mucus layers in the colon. Really that dense inner layer with few microbes. So just that thick mucus is there to make it much harder for the various bacteria living there being able to get close to or get into the crypt. And then also these areas, they contain things like antimicrobial peptides. So that helps to also protect. So if bacteria are getting too far, it can help to push them away. And then, of course, we don't really want a very thick mucus layer in the small intestine because that's going to affect absorption. So naturally, things are different depending on which part of the gastrointestinal system we're actually looking at. So this image is pretty cool, as well as the last one. I mean, it shows the anatomical differences between the small and large intestine. In the small intestine, we have villi, and that's of course to increase, or if you like, maximize the uptake of nutrients. But those finger-like projections, they also help to stop bacteria getting into the crypts, because we don't want them getting down there and possibly damaging the intestinal stem cells. So the villi act as a physical barrier, but they don't have that dense mucus layer, because of course, remember, that inhibits absorption. Then we have the intestinal stem cells at the bottom of the crypt. They replace cells of the epithelium, different places. We have these Paneth cells. They're known for secreting antimicrobial peptides, but also nutrient sensing, primarily mTOR, and that signals when it's time to proliferate to the stem cells based on nutrient availability. And then we have things like goblet cells to help develop the mucus layer, enteroendocrine cells to help regulate digestive processes. So lots of different cells here performing lots of different functions to kind of assist in a whole variety of processes. So we want, of course, all these to be as healthy as possible. Now, here on the left, we have a healthy symbiotic situation. We have good epithelia, healthy goblet cells secreting mucus and helping to separate the microbes. Interleukin 10 is present, and that helps to keep the immune system calm and regulate the microbiome. There's, as you can see, a much nicer, thicker mucus layer. Barrier function is maintained. There's no pathogenic bacteria approaching the epithelium, and the tight junctions are working really well. We want mucus turnover to happen, because if it stagnates, then it's going to likely accumulate a lot of microbial products. Of course, we know certain bacteria really can help with that, like Akkermansia, for example. And this is also why it's important to have clear feeding and fasting routines in your client or patient, because that's going to help with the things like breaking down the mucosal tissue overnight, essentially to help that process. And then of course, on the left still we have pathogen growth is controlled. We've got T regulatory cells controlling inflammation, and there's immune tolerance occurring. So of course, what contributes to that? Well, it happens that if you're a healthier person, then you're more likely to have a healthier barrier function here going on. Avoidance of a Western diet, no medications, young age, because of course we're much tend to be much healthier the younger we are. But of course we can delay biological aging through various techniques. Clean water, clean air, so things like pollution has been shown to be very problematic for the microbiome. So you think about, of course, where your patient or clients live. Opposite end of this, on the right hand side, we have epithelial cells breaking down, poor goblet cells, mucus turnover is disrupted. We've got too many pathogens, like actually getting too close to where the real immune system, and getting this crossover into the body, so into those deeper layers of the crypt. Might have an increased Th2 response, so we've got dysregulated immunity. We've got more poorly adapted microbes, ones that are not evolved with us, so they can be more problematic for us. And yeah, if we could pick one, especially one condition that really is going to contribute to this, it's something like type 2 diabetes. So it's really important, if you want your client or patient to have excellent gut health, then they need to be metabolically as healthy as possible. So yeah, other minor things like watching out for antimicrobials in food, such as food preservatives, because that can also impact the situation. And of course, when we're getting this kind of level of damage and encroachment by pathogens, stem cells can be impacted. So then it means that we can't get this kind of refresh process going on. When we get into the IPA test, we've got these 6 different sections from top to bottom, and it uses a traffic light system, which is very easy to understand. Obviously, red for bad, green for good, and yellow for somewhere in between. So if we go from the top, we're looking at everything from absorption capacity. We're then looking at intestinal permeability, gastric permeability, intestinal damage, and then lactose and sucrose intolerance. So how the test works is that before your client or patient goes to bed, they will drink a 5 sugar solution. And what we're doing is, at the lab, we're measuring as they collect their urine overnight if they go to the toilet, and then typically their first morning urine, looking to see which of those sugars have been absorbed and which haven't into the body. Now, of course, some of these sugar molecules, if we take, for example, mannitol, then we want that in the absorption capacity box. We want that to be absorbed easily, and it shows that the mucosa is working well. Then we have something like intestinal permeability. So if we have high values here, this again is a sugar molecule that is typically indigestible. So it shouldn't have crossed the mucosa barrier. So again, something's inflamed there. We've got hyperpermeability going on. Then we have gastric permeability. So the same situation going on at that point. And then intestinal damage. So usually if we've got a red score there, there's more significant inflammation going on, or villi health is more affected. So particularly with celiac disease patients, I really like to run this test because I like to track their progress over time to see how not only is just the removal of gluten actually working, but how are the other techniques also that we're employing, how are they doing? Then, of course, we have lactose and sucrose intolerance. So that can be a bit easier, of course, if they're lactose intolerant. You can remove lactose from their diet. Sucrose, a bit more difficult. You can give an enzyme containing sucrase, and you can advise them to avoid high foods that are higher in sucrose in general. See it occasionally but it's not so common. But of course, with this test, it's going to give you all these markers. So it's going to tell you that if absorption capacity has been affected, if there's hyperpermeability of the gastric or small intestinal mucosa, if there's inflammation and damage going on, but it's not going to tell you why. So that's where you've got to do the detective work yourself. Why are the values abnormal? So maybe if there's high gastric permeability, you might consider Helicobacter pylori. Again, if there's high intestinal permeability, you want to consider things like hyperglycemia. Remember that patients can respond differently to different foods. So often we'll be using continuous glucose monitors to look at that. You've also got other factors like stress level that can affect the intestinal permeability. So when we look at from a research perspective, the main drivers of intestinal permeability, we've got alcohol, hyperglycemia, poor sleep, a Western diet, circadian disruption, and stress. So your patient may be great at avoiding a Western diet. They might have the best diet in the world, might not drink any alcohol, but if they're really bad at managing stress, then they could have high permeability. So that's often a question I see when talking to a lot of practitioners. I don't understand, my patient's perfect, but they have hyperpermeability, but that's because this hyperpermeable situation is dependent on many factors related to them and the environment. So you can't just expect to give a supplement to try and reduce permeability and expect it to completely solve the situation. You've got to look at underlying factors. Could be also things like infection, fungal, parasites, possibly SIBO. So there's many different contributors here, and you're going to have to do that work. You're going to have to especially work on metabolic health. A lot of patients are not metabolically healthy. We see changes in CGM markers very early on. So they might be great from a HbA1c perspective, fasting glucose, maybe even an oral glucose tolerance test. But yeah, you're going to have to use maybe some of these really early markers, like a CGM, continuous glucose monitor, way early to look at things like metabolic health, because again, they could be having quite high reactions to certain foods. So in regards to how do you treat the different areas of the report, well, absorption capacity, if that is affected, you might want to try a digestive enzyme, something like this one I use quite regularly from Pure Encapsulations here in the top left. Then we have intestinal permeability. So then all the supplements on the right-hand side of this slide, like GI Revive, Permavite, Mega Mucosa, they're like multi-ingredient products that I use. Maybe I wouldn't use them with sensitive individuals that have something like mast cell activation syndrome, or react to a lot of things in general. I might go more single interventions, whether it's something like deglycerized licorice or aloe vera or marshmallow root, slippery elm powder. There's no general consensus about what is best, but of course with the gastric mucosa, it might be that something like Endocin is better because of the zinc carnosine content. And then I really like Megaspore Biotic, because it's been shown in the research, due to the strains that contained in there, that it's actually can reduce endotoxin 5 hours postprandial situation by about 42%. So basically it's a nice, really nice probiotic that can possibly improve intestinal permeability by reducing serum endotoxin concentrations, because of course, well, either it's binding to the endotoxin and preventing absorption, but endotoxins are inflammatory and they will drive up permeability. So yeah, it really depends on the patient, depends on what area. Again, you've got to do your background detective work to try and understand what is driving that situation. Don't expect in all cases to just give some kind of mucosal barrier support and expect it to solve the symptoms. You're going to have to, work on both sides to try and solve the underlying factors. So these are just some of there's a lot of products out there. I know a lot of practitioners have many different approaches. Again, as I'm always saying, I'm not saying that I have exactly the right approach and these are the best products. They're just some of the ones that are used. But I really think it's the ones on the previous page here that you're going to have to really get focused on to resolve this situation long term. So that is the intestinal permeability test in a repeat. So we'll take questions at the end again, so we can jump into the IgG testing. So IgG testing has often been primarily used in irritable bowel syndrome. I mean, it begins with a test usually to identify foods that cause a high IgG antibody response. And the theory has been that this high IgG antibody response is causing, or this excessive response is causing a reaction in the individual, and therefore it's a biomarker of intolerance to that food. So by decreasing the consumption of these foods, it can lessen that reaction, and that may, of course, reduce symptoms in the process. But on the flip side of that, another view is that IgG antibodies may not be a marker of intolerance to food, but they may be a marker of just how much of the food people eat. And higher IgG antibodies may simply mean that you eat those foods more often, and then it's like promoting tolerance to those foods. So there is evidence on both sides, you might consider an IgG test in multiple type scenarios. And I think I'm going to divert again to Anne-Catherine here. She gave a great explanation last time how she started to, how she got into IgG testing, and then how that kind of developed and how she uses it. So I'm going to hand over the microphone, so to speak.
I'm here. Can you hear me? Or
yes.
Louder?
No, you're good.
I'm good. Good. Okay.
Yeah.
So, well, the story that I would share with you is more like 22 years ago, or whenever it was that I started as a practitioner, I really only had the food intolerance test to use. I didn't have stool test. I didn't have organic acid test. I didn't have SIBO test. I didn't have the intestinal permeability assay. So that was kind of like the message that I could work with, and I had people contacting me because they had heard others had felt better when they had done the test. And so we kind of worked with that, and also worked with the idea that it helped people with IBS symptoms, but it for sure also helped people who had more extra gastrointestinal symptoms. So, but anyway, the experience, and that's where the empirical documentation, you can say, is very, very valuable, because we were many functional medicine practitioners back then who were using this test, and we saw these kind of miracles, how people could feel better when they removed their foods, and whether it was due to exactly that or placebo. Of course, we don't know that. There are some studies that has like weak indication that the test is working in IBS. There's some in regards to migraine, but the research is really, it doesn't match what we see in the clinic when we work with this test as a tool. So this is definitely a test that I have continued using for all these years. I'm using it less now than I was then, because that was kind of my go-to tool. But now I have all the other tools. So now I use the test for if I have a patient who has pain, joint pains, migraines, skin issues, like swelling up, so like retention of liquid, inflammation, like inflammatory feeling in the body. So where I kind of use it to remove, how can you say, provocation in the body, in order that I'm hoping that the immune system can heal up better and the gut can heal up better when it's not continually provoked with something that it has to produce antibodies to. So that's kind of when it's a little bit more challenging. It's not just, and I'm not at all, because IBS is not a just condition, but when it's only like gastrointestinal problems, I don't really use the food intolerance test. I actually even say to people, I don't think you should use that test as #1 test. I would rather do a stool test or SIBO test or wherever we are. So then we may go back to a food intolerance test if things aren't solving, but that is not the first choice when it's just gut problems, at least from my experience. So, but when there's gut problems and all sorts of other problems, then I'm for sure using it. That's just my take on it.
Great, thanks, Catherine. So yeah, I mean, of course, still a lot of questions with this. That is it just that when people are eliminating those foods that come up as high response, are they just changing to more nutrient dense foods? Are they avoiding more of those higher calorie, lower nutrient foods like gluten or milk, dairy products? And is this just really promoting better dietary patterns and more education? And I think that's good. One of the things with when patients get the test and they see the red lines, that it does elicit a kind of response where they're like, no, I'm willing to change and move away from these foods that are in red for a period of time. And of course, different practitioners use different elimination periods. I mean, personally, I've used more like 3 to 4 weeks to see if it has any effect. But I know Anne-Catherine uses slightly longer, up to 6 weeks. And of course, some of the laboratories recommend up to many months. So there's a lot of different thoughts around this this test. So when we, of course, look at the results, so here's an example here. Everything in red has elicited a higher IgG response, and then that's graded into 1, 2, or 3. So depending on the amount of foods that are coming up here, it may be that you start with all the 2s and 3s, or just the 3s to start with. But again, it doesn't necessarily mean if there's a higher IgG response that a 3 over a 1 might be a better choice necessarily. I think Anne-Catherine, before you talked quite nicely about how you might remove them, or basically how you approach the different levels. I don't know if you want to say anything a bit more about that.
I can do that. So there are some clinics who only, and this is just like, again, throughout the years where we've been discussing these tests and why is it that it will work and how should we use them as a tool. So there are some clinics that, well, doctors that I know or practitioners that I know are only removing the +2 and 3, and then they're maybe only removing them for 3 weeks to try and see if they can reduce or introduce them back again into the diet. So that's one way of doing it. I have never worked that way personally with it. I have always tried to open up and say, well, let's remove them for at least a period of 3 months. Maybe longer if it's not possible to introduce foods after 3 months. So I'm working more with a theory where with IgG foods, it's not a, well, it can be a more permanent allergy, but that it's not really the definition allergy when it's an IgG reaction. It's more like a food intolerance, I would say. But it can, some of the foods can be more permanent where the body just continue reacting to them. But the theory is that we remove the foods for a period of 3 months. In that period, hopefully the IgG antibodies have stopped being produced, like Graeme also mentioned earlier. And then, so it's the immune, it's the tolerance. And then we can introduce it again without the immune system reacting now. So it's kind of forgotten that it used to react on it. So there are some labs who's opening up and say, well, if it's a +1, remove it for 3 months and try and introduce. If it's a +2, remove it for 6 months. If it's a +3, maybe for 12 months. So because, you can see at the bottom of Graeme's slide, there are some with 3 stars or a number 3. There's some with a number 2 and some with a number 1. So that explains the severity of the reaction when the blood is in contact with the food. So the immunological response is what the number represents. And then I can also open up the lid a little bit, like if I've had a patient who has been on immune suppressant drugs, then, and we've done an intolerance test. I mean, even though perhaps you shouldn't, because the immune suppressant would maybe not make the patient make so many antibodies on IgG, but then I'm a little bit like sly sometimes, because then I might look at the number, and you can see there's a number next to the food, and the number, so if it's 0.299, that's kind of like the cutoff for the 1, and then if it goes above 300, it's a 2, and if it goes above 400, I think it is, it's a 3. But then let's say I have a patient who's reacting close to being positive, then I might remove it if they are on some immune lowering medication. But I'm using it as a clinical tool, more as a, this is your black and white list of what you're allowed to eat and not eat. It's a tool, and we can discuss it, and how do you feel and how do you react, and let's try and see how you are when you're not having all these foods. Let's kind of remove all the background noise, or as much background noise we can in this patient, in the hope that the body is able to heal itself, is kind of how I work with this test. I use it also like in autoimmune conditions. I didn't say that before. So I have this autoimmune Hashimoto's patient with severe migraines in mind, and we've actually done several tests on her, and it's quite interesting to see. So she removes the food. So when we did a follow-up test about like 6 months later, I think the first follow-up was, then she had less foods, so less red reactions. Some of the 3s had gone to 2 and so on, but she had also had new foods, and then some of the new foods were then the foods that she had prioritized to eat, now being on this elimination diet. And so is that because the gut has not healed up, the leakiness is still there, so there's food, it can cross the gut barrier and it creates an immune reaction. Is the theory is that we are we are working with when doing this test. And then I think we've done 4 food intolerance tests on her throughout the time, because she could really feel a difference in her energy levels, in her migraine levels, in her general like well-being. So it was an important tool to her, and also she was very interested in all this and wanted to work with all this, and wanted answers. And the more we tested, the more answers she got, and the more close she got to understanding her own body as well. So yeah, that's just some examples of how I worked on it.
Thanks, and Catherine. And yeah, that, I mean, you reminded me, there was actually a pilot project in Stockholm quite a number of years ago, which looked at autoimmune thyroiditis, and there was a number of tests. It was kind of a functional medicine research, but it wasn't. I mean, the tests were set. They didn't pick the different tests, but they did slightly differ on the interventions. And of course, one of the tests was this IgG analysis, and the participants in that study, actually all of them felt that this was the best test, even though they did other tests alongside it. They felt that this was most empowering, and a lot of them had very good things to say about the test. And there was a significant TPO antibody reduction over the study. I can't exactly remember all the figures, but yeah, I mean, this is, I think, when used properly, a lot of clients or patients, whatever you call them, they do respond well to it, or they can respond well to it. But like Catherine says, I mean, there's a lot of pros and cons to the test, and the data is really not clear, especially in using it for maybe IBS alone. But we see with perhaps more systemic conditions that whether or not this just promotes different foods and more nutritious foods, and it changes the composition of the microbiome, probably has a whole number of those effects combined. So I think that's where this test gets interesting, because it can help to drive behavioral change. And of course, that's why most of us, probably all of us, are on this call, because we're fundamentally interested in how behavior and nutrition and lifestyle factors really drive disease. So yeah, I think that's well, we're over to the Q&A. I think maybe take 2 was maybe slightly better. I think
well done.
Practice makes perfect.
Practice makes perfect. Yeah. No, I think you did very well in both take 2 and take 1 as well. And I don't think you missed out anything.
We're not going to get the US start to log in now, I hope.
There are some people logging in now, not as many as an hour ago. So anyway, well done. And yeah, I hope you appreciate that Graeme just did this again, because it's not an easy thing having to repeat everything you've just said once. So anyway, well done, Graeme. So I had there was a question that came up from Dr. Sandra, and it was in regards if you had any experience with melatonin and intestinal permeability, if melatonin can help the healing. I think the question was on. I don't have any experience with it, and I haven't seen any research.
I mean, we do. I mean, yeah, at the clinic, I mean, we do prescribe, or now even in Sweden, you can actually you can now buy melatonin over the counter, which was new as of some point earlier this year. I can't say we've tracked it closely enough, and clinically, I'm going to run, depending on the patient's budget, we're more likely to run other tests potentially ahead of an IPA test, because of course IPA is more like a monitoring of the situation, rather than, it's not giving you necessarily root cause issues of the problem. So especially if it's like IBS, like Catherine said, as more tests have come onto the market, we're more likely to run a SIBO or a stool analysis test over IPA and to understand what's going on there. But the more systemic issues, the more unexplained symptoms, and especially for things like celiac disease, then I really like to run an IPA test to monitor progress, or autoimmune disease to really kind of monitor progress and try and stop that hyperpermeability occurring, which maybe is, again, I think the words Anne-Catherine used in the first seminar, which I'm now going to steal, is like background noise that's occurring due to like immune provocation. So yeah, we've never done like specifically with melatonin, but of course we know that melatonin has motility effects and effects in the gut. And so we can see with things on like low melatonin on Dutch tests, and then just melatonin prescription or supplementation, that a lot of symptoms improve in general, because then people are getting more restful sleep. And we know that poor sleep is a contributor to hyperpermeability, as we went through in the presentation. So yeah, extrapolating all that, I would expect, if the patient is insufficient or deficient in melatonin, that prescribing melatonin would help. Yes.
And Dr. Sandra also is asking like about the vagus nerve status, if I guess supporting that will support the permeability and maybe even lower the food intolerance.
Yes. Yeah, so of course, just working on the basis that we know that stress really drives up hyperpermeability. So if you can stimulate the vagus nerve, and there's a lot of different ways of potentially doing that, then you can potentially drive down hyperpermeability. But of course, hyperpermeability, as I kind of alluded to throughout both presentations, is a combination of multiple factors, from probably personality to the environment to, of course, all these other things like medication, pollution, what you ate, how much you've exercised, your metabolic health. And it's like a dimmer switch that's going to go up and down. And of course, sometimes the gut is going to be more permeable, and sometimes it's going to be less permeable. But of course, ideally, when you're testing in the morning after that ingestion, or overnight, you're testing the urine. I mean, we do want those tight junctions to be able to seal up. Yes, so I hope that explains a bit more.
So now, sorry if I'm saying it wrong, but Maeve had a question. I'm just going to read it up, and then I'm going to try to see then you can see what I think, and then Graeme may say something else or add something. So I have a child client with multiple IgE allergies. However, eczema is still prevailing, as well as constantly runny nose and hay fever type symptoms. So I was wondering if we should now do an IgG test also. Now, I would also probably in a case like this. Now, actually, let me just say something first. When I'm dealing with children, I ask the parents, how busy are you in getting your child feeling better here? Are you in a hurry? Or are you wanting to spend the next year getting your kid back in shape? And most of the time they say, we want this to happen quite quickly. And then I suggest that we do for several tests and not just one. So with a case like this, I would do both gastrointestinal tests. I would probably both do an organics, and I would do a stool test, and I would probably do an IgG test as well. and then I would work with the parents and go through the results and put up a program that includes supplements and nutrition in the case of that patient. Would you like to comment?
Sure. Yeah, I mean, I think you probably like covered how we would generally do it. I mean, overall, we don't see so many children here at Nordic Clinic in Stockholm. It's not a group we particularly target, but they do come through, of course.
Let me say why, and that's because in Sweden there is a law that it's only doctors who's allowed to treat children below 8, or is it 12?
Yeah, it's 8 years old. So actually, if you're not, well, because we're a medical clinic, so even people who are not medical doctors but they're working within a medical clinic, that's okay, because you're supervised by medical colleagues. But yeah, in Sweden there's actually what's called the it's a quacksalveri law.
That's quick watch.
Yeah, which does prevent, if you're not a medical practitioner, then you can get quite a heavy penalty if you're working with children under 8 years old. So I think there's just quite a bit more hesitancy in Sweden in general for any practitioners, even medical practitioners that are not pediatricians, to work with children, especially on areas like this where it's a little bit controversial as to what's maybe being used in regards to interventions. But I think I would definitely be looking at stool analysis for sure. So I think Anne-Catherine gave a good answer, really. How much information do they want? How quickly do they want that to happen? Of course, a lot of children have a lot of immune symptoms as they're growing up, and then they grow out of it. So that's always again a question that we have. I mean, how problematic is for the child? Therefore, how much do we want to potentially change things? We don't want to potentially cause like nutrient deficiencies by excessive elimination diets. So, and of course, Anne-Catherine is a dietitian and trained to deal with those types of things. So usually with children, it would be more like I would have one of the doctors and the dietitian potentially working together on a case like this.
So another question is, in adrenal fatigue, when IgA is low, if we see lower food intolerance reactions. I hope I'm understanding the question correctly, but we are looking for the food intolerance test here with the one that Graeme presented is the IgG one. I can't say, I don't have experience with IgA food intolerance testing and a correlation with secretory IgA. So I'm sorry, I can't answer that one. But if you find out, any of you, please let us know so we can share that one.
Yeah, I mean, I think, of course, adrenal fatigue has been quite well. I mean, it's more that you've got HPA axis dysfunction. So it's just that there's not as much bioactive cortisol circulating. We can see patients with, if we do stool analysis, then we can see low secretory IgA on a result in those patients with kind of burnout type scenarios. So I think there's possibly a correlation there, but you can also see patients with burnout that have high secretory IgA. So I'm not sure. Haven't looked at papers for a while to quote exact levels. But of course, one of the things with low, I mean, we don't know, is it genetic? We often don't have enough like data going backwards in time to compare different time periods of life to say that it's just purely due to stress. Or, I mean, I think secretory IgA, especially in the gut's, affected by so many factors that it gets very difficult just to pin that on one thing. So not using like secretory IgA levels in gut testing to really drive intervention directly. It's just more, I'm using that more to track what's going on. So if I'm doing an intervention and secretory IgA in the gut is or in the stool is low, and then the levels are increasing with follow-up tests, then hopefully it's indicating that we're doing something correctly.
Super. Then another question comes up, and that's the take on L-glutamine for increased intestinal permeability. I think you already mentioned some of the products that you mentioned. Both Indocin contains glutamine, and some of the mixture for the small intestine also has glutamine in it. You can get glutamine by itself, but this question actually goes more along the dosage. And also, how often would you follow up for someone with increased permeability?
Yeah, I mean, I would use glutamine, and I think I said in the presentation that if you get a more sensitive patient that reacts to a lot of different foods, and they're very hesitant to try a lot of things, and also we don't want to use maybe a combination product like GI Revive, then it may be that we'd start with something like L-glutamine. But my general experience is that you can give a number of grams of glutamine, but if that person is drinking alcohol and highly stressed and has poor sleep, maybe it's offsetting a little of those effects. But of course, it's fundamentally really, it's not a lack of glutamine which is really driving up permeability. It's of course behavior and lifestyle which is predominantly driving that up. So of course it might move them in the right direction, and it might help you to offset some damage while they're maybe not prepared to change all of their lifestyle. But yeah, I mean, the question is, I would certainly use probably a couple of grams. I would probably use it for as long as their lifestyle is potentially not getting into the right place. But I mean, that could be months, it could be a year. But am I going to use it for a year? Probably not. I'm going to maybe use it at times. So if they are going to drink alcohol, then maybe I'm going to use more glutamine, the day before, during that day, the day after, because generally, unless there's a real clinical reason for it, I'm not a fan of using like supplements consistently for long periods of time. I'm just using them to try and either correct deficiency or move them in the right direction, which buys time to actually correct lifestyle and behavior.
Excellent. So we had a question earlier about I was just talking about this patient where he was really malnourished, 35-year-old. Half of his time on his life he was lying in bed in a black room. So really he was not 35 years old, he was half of 35, or since his migraine started, because he hadn't lived half of his life, he had been in bed half of the time. And he was all like waxy in the skin and yellow, and he was really malnourished because he was only eating white bread, actually with gluten, but that didn't seem to be a problem for him, and a few meats and olive oil, and really not anything, because foods were giving him a migraine and making him worse. With him, I started with, gave him some Indocin, and I asked him to open up the capsule and pour it into water and just mix it up and just take a sip and see how that went. And later take another sip and see how that went. And that way, slowly increasing the dosage. And then the question was, well, why did you open the capsule? And when I can, if I have a very sensitive patient, then if I can, I ask them to open up the supplements and start at a very, very slow dosage, 1/10 or just a sip, which may be 120 if it's in a glass. Really I don't want them to feel bad because we're starting a treatment, but sometimes the gut has to get used to getting glutamine and getting the zinc and getting the nutrients. It kind of has to wake up, and this wake up process makes them feel worse. So I'm sometimes very, very careful, and I'm never really the one who goes, well, if it says 2 scoops on the pack, 4 must be better, kind of. But I may do that, but then I will do it where I slowly ask the patient to increase the dosage step by step over time, so they don't feel worse and we don't create like a Herxheimer reaction on them and so on. So I think we've been through.
There's a question here from Anna that says, would you consider IgG testing for autism, ADHD if they don't have any gut or skin symptoms? But I mean, I know you've worked with a lot more autism and ADHD children than I have, and Catherine, but I think certainly.
Well, I said, I answered that, and I said,
oh, you did?
So maybe you can't see my answer. So I said possibly because there's a brain, nervous system, immune reaction connection as well, that's sometimes important to remove the background noise to let the immune system and the nervous system calm down and so on. But I'm saying possibly because I may not do it in all. Because if the opioid theory, that would be my first go-to with these kids, where we remove gluten and casein in order to remove the morphine peptide-like substances in the body. If that works, I may not go that way, but it's again this Fingerspitzgefühl, as the Germans say, like you get this feeling with the patient and the conversation with the parents, and where should we go? So that was it's difficult to answer, and I also said, well, and maybe work more with the gut and nutrition before I would go for an IgG. So that's perhaps my IgG is a little bit longer down the line in my first choice of test when I work also with the kids. I hardly ever measure the morphine peptides because that's a way where I can save the money maybe and just spend it on an organics instead. And then we just test the gluten, casein, opioid theory out in practice with the kid. But because if the test is positive, it's an indication to try out the diet. But the proof is if the diet is responding positively when it's on the diet. So that's more why I kind of sometimes avoid the test. But if I have parents who are very left brain dominant and they need evidence and they need an answer if this kid is producing the morphine type compounds from dairy and gluten, then we do the test. So a lot of parents to kids with autism and ADHD are left brain dominant. So a lot of them are engineers and like in that field, and they need some statistics and some numbers and so on. And for those parents who are aware of this, we are just laughing about it because that's just the way they are. Then there's some who's not quite aware of it. But then I use the test if the parents want like evidence for it. But otherwise, I would go for just trying out the diet, use organics, maybe hair test. I can't do blood on kids myself. So I use a hair, even though it's maybe a questionable test, but it gives me some indication at least. And then stool tests as well if they have gastrointestinal challenges.
Great, thank you. Emily was asking a question, but I've answered it in the chat. Emily at the bottom.
Oh, I think you answered it in the waiting room.
Okay, well, that's helpful. Sorry, Emily, but Emily, I would run a stool analysis ahead of, so in your, Emily's asking, would the IPA test be adequate for a woman who has lost a lot of weight, has a hard time digesting protein and taking up nutrients, constipation. So yeah, basically she's on gastric acid suppressants as well. I would be running a stool analysis and a SIBO test probably ahead of an IPA. You could run an IPA alongside it, and I would probably be I want to know, have the doctors actually ran an endoscopy and possibly also colonoscopy as well, because weight loss, which, well, I don't know how much she's lost because you've not stated, but usually those kind of symptoms would prompt actually. So she's saying Emily's got a CT scan, okay, and fibroscopy. So yeah, I would, if things have been ruled out there and it's a green light from the internal investigation, then I would definitely be running a stool test ahead of the IPA.
Or both at the same time.
Yeah.
Yeah, you can see I'm quite aggressive on doing more, because then it may be that we know something, but then there's something we don't know. We could get that answer as well. So I'm a little bit more aggressive when it comes to that, but it's the conversation with the patient as well. Yeah, I think we all have to leave now. Graeme has been talking for over two hours now, the same, a copy. But thank you so much, Graeme, for doing that. That's hard work. You prep yourself for the first one, and then, oh gosh, I have to do it again. So I'm just going to think, am I going to publish the first one or the second one? I think
the second's better. I think the second's better.
Sure. I'm going to delete the first hour, and then I'm going to publish the second hour. Thank you everyone for coming in and complaining that we were about to stop and you had planned the day around this, and so had we. But now it's time to relax, especially for you, Graeme. And thank you everyone for checking in, and we will send the recordings as soon as we can. Maybe tomorrow, maybe Monday, Tuesday. Let's see. We'll do the best we can. For you, because it's important to support your further education within our field. Thank you very much, everyone. Bye.
Okay. Bye.